Let's talk blood pressure medicines today. What if I told you that there is a widely used medicine used in every single emergency department? It's used in every single urgent care, and it is widely prescribed on an outpatient basis, but it was never designed to treat blood pressure in the first place. Curious? Fantastic. Take a seat, lock in, and let us learn about clonidine. Clonidine, oh my God, I'm excited already. Clonidine is an alpha-2 agonist, meaning it works in the brain. It was designed to work in the brain, initially created to treat sinus congestion. And then along the course of time, providers saw that it had a pretty profound impact on blood pressure. So they said, let's start using it for that reason also. Ooh, let's unpack this. Clonidine, being an alpha-2 agonist, means that once it attaches to its binding site, again, in the brain, it causes a decrease in the production of norepinephrine. Why is that relevant? Because norepinephrine is a huge role player when it comes to the body's fight or flight response. When norepinephrine is released into circulation, it puts the body into a heightened state of awareness because, fight or flight. When the body is in a heightened state of awareness, heart rate goes up. Blood vessels in the periphery constrict. That causes blood pressure to go up. Clonidine, being, again, an alpha-2 agonist, it tells the brain, that fight or flight response that you got, let's dial that down. Dial that down. When that dial down happens, the release of norepinephrine comes to a stop. We don't do that when clonidine is in the picture. Norepinephrine is a no-go with that. When you stop the release of norepinephrine, then the exact opposite will start to happen. Heart rate then becomes lower. The arteries in peripheral circulation will actually dilate. So when you have a lower heart rate, you have decreased vascular resistance, blood pressure is going to come down accordingly. Now remember, I told you it was designed to be to treatment for sinus congestion. How does that even work? Turns out that alpha-2 receptors have different not accessibility, find your word. Alpha-2 receptors have different receptor activity depending on where they're located. And turns out in the nasal mucosa, the opposite effect happens when these alpha-2 receptors are triggered. Instead of a vasodilatory effect in the nasal mucosa, you actually have a vasoconstrictive effect. So inflammation is reduced, sinus passages are opened, you can breathe again. Now, mind you, this is dose dependent. So don't think that, every dose of clonidine that you give intentionally for blood pressure is going to cause any sort of nasal congestion relief. Not necessarily, very dose dependent. Why is clonidine used like it is in emergent and urgent settings? It's because, one, it works fast. Onset, and again, dose dependent, depending on the patient's individual clinical context. On average, oral clonidine will work in about 15 minutes on average. Now, clonidine also comes in patch form. We'll talk about that in just a minute. In oral preparation, though, onset of action is about 15 minutes or so, and you are going to have a profound effect in blood pressure dropping. Now, bear in mind, you got to have a backup plan with clonidine. You can't just give somebody clonidine and then, expect that their blood pressure is going to act right, moving forward. You got to have a backup plan because clonidine has a very short half-life in circulation, meaning it's going to start to make its way out of your bloodstream in just a few hours. So have a backup plan. If you don't have a backup plan for your patient's blood pressure, that blood pressure is going to skyrocket again, because then the brakes that were put on the brain to tell the norepinephrine release to come to a halt, the brakes are going to be lifted, blood pressure is going to skyrocket, and you're going to have what is called a rebound effect, especially when it comes to tachycardia, rebound tachycardia. So bear in mind, you do not want to give clonidine for good intention in an inappropriate patient. So if you have a patient, hypothetically speaking, you have a patient who has elevated blood pressures of like 180s over 100s, and they're also tachycardic, don't give them clonidine. Please don't do that, because you are going to send them into some sort of tachyarrhythmia response. Anyhow, patch formulation, clonidine comes in patch form also. If you are going to prescribe your patient a clonidine patch, that patch takes a little bit longer to activate in the bloodstream compared to its oral counterpart. So have some other blood pressure medicines on board, because it's going to take about a good day or so for that patch to actually kick in and produce a desired effect. Also, nursing students and new graduate nurses, for your patients who are on the clonidine patch, please tell them to change their patch sites. Now, the patch has to be replaced weekly. And you don't want to just take one patch off and put the next patch on at the same place. It's got to have a different site, because you'll end up decreasing absorption and bioavailability if you don't change your sites. Wrapping things up. Clonidine works in the brain, created for sinus congestion, works wonders for blood pressure in the right patient. Do not, hear me, do not discontinue abruptly, because you are going to have that rebound effect of hypertension and tachycardia. Have a backup plan in place. Rapid onset works well for the right patient. Geek out controlled. If this information has been helpful for you guys, you know what to do. Hit your buttons. Nursing students, if this is new information to you, share with your classmates, please. Nursing preceptors, please educate your patients, your students about this, because I think that they'll be equally as fascinated about this medication as I am. You guys have any questions whatsoever, you all know I am happy to clarify anything whatsoever. And as I'm trying to contain my geek out, I will leave y'all with two final words. Class dismissed.